Welcome to the Emergency Medicine Cases podcast. I'm your host, Dr. Anton Hellman, bringing you Canada's brightest minds in emergency medicine from EMC Studios in Toronto. EM Cases is part of SREMI, Schwartz-Reisman Emergency Medicine Institute, the nonprofit organization dedicated to improving EM care through research and education. The opinions expressed on this podcast are intended for information and education purposes only and should not be used to diagnose, treat, or prevent any medical condition, nor should they be used as a substitute for medical advice from a qualified practicing physician. By far the most popular blog series we've ever had on EM Cases website is the ECG Cases blog with ECG master Jesse McLaren. You've also probably heard Dr. McLaren on our EM Quick Hit series. Well, I've got big news for you. Jesse McLaren now runs online ECG interpretation courses for every level of experience. The name of the course? Hearts. This is the best way to up your ECG interpretation skills and pick up those life-saving ECG subtleties. There's an upcoming course designed specifically for EM residents and registrars, May 18th to 25th. There's an advanced Hearts course for practicing EM docs, June 23rd to 30th. He even offers courses for paramedics and medical students too. These are expertly designed, clinically focused, simple, and systematic approaches to ECG interpretation specifically for emergency providers. All the info and easy registration is at heartsecgcourse.com. That's heartsecgcourse.com. Subarachnoid hemorrhage is bad. 50% mortality rate with half the survivors suffering from significant chronic disability. I was a bit surprised to learn that a whole 1/4 of patients die in the field before they even get to the emergency department. Of those who make it to the ED, a few will be crashing in our resuscitation rooms, but most of them will just have a headache. So the problem we face in the ED with subarachnoid hemorrhage is twofold. First, the clinical manifestations range from just a headache alone, maybe it's a sentinel leak, and that ranges all the way to comatose and death, a highly variable presentation with or without focal neurologic signs. The second problem is that once we identify a subarachnoid bleed, secondary bleeding and ischemia snowball fast, leading to delayed badness. It follows that our job in the emergency department is really twofold. We need to find the needle in the haystack of headache-alone patients who have a subarachnoid hemorrhage, that tiny little sentinel leak that if you pick up now can prevent a giant bleed and death later. And the literature suggests that we're actually not great at this. In fact, rates of misdiagnosis have been estimated to be as high as 7%. And our second job in the ED is to manage the sick subarachnoid hemorrhage patient who's already had a big bleed, to prevent further bleeding and ischemia and insult to the oh-so-delicate brain. Now, we have the honor of having two fantastic guest experts on this podcast, Dr. Jeff Perry, an EM doc and Vice Chair of Research and Scholarship at the University of Ottawa, Department of Emergency Medicine, home of the Ottawa ankle rules, Ottawa CT head rules, Ottawa C-spine rules, and the Ottawa subarachnoid hemorrhage rule, which we'll be speaking about in this podcast. And our second guest expert is Dr. Katie Lynn, who you may remember from her captivating talk at the last EM Cases Summit, an EM doc who is also on the stroke team in Calgary's Foothills Hospital, our go-to educator for neuro-EM. Welcome, Dr. Perry, and welcome, Dr. Lynn.
Thanks, Anton. It's such an honor to be here.
Thank you for the invitation to come to this podcast.
Fantastic. So let's start with a case. A 55-year-old male with a history of alcohol use disorder was at home when his wife heard a thud in the adjacent room. She found him lying face down on the floor. She flipped him over and he was barely responsive. EMS measured a GCS of 12 on their arrival and a GCS of 14 on arrival in the ED. When you see him in the ED, he complains of a diffuse headache and has a large gash over his forehead with a sizable hematoma. A CT head and C-spine reveals a subarachnoid hemorrhage, a small amount of blood in the right ventricle and a small amount just adjacent to the midbrain. I think we'll stop there with the case, and we'll come back to this case a few times, I think, during the podcast. But first, we need to figure out how the subarachnoid happened in the first place. Dr. Lynn, what are the most common causes of subarachnoid hemorrhage in general? And in this case, how are you going to figure out what the cause is so we can guide our management accordingly?
Well, Anton, we consider two different distinct types of subarachnoid hemorrhage, traumatic versus spontaneous or non-traumatic. The reason we think about them in two flavors is because the etiology of subarachnoid hemorrhage dictates very different evaluation and management, and that's why we care. So, trauma is the most common cause of subarachnoid hemorrhage overall. We know that about 30 to 60% of patients with moderate to severe head injury actually have a subarachnoid hemorrhage. If we think about the kind of flip side, spontaneous or non-traumatic subarachnoid hemorrhage, aneurysm rupture or leak becomes the most common cause, accounting for about 85% of spontaneous subarachnoid hemorrhages. Other less common causes of spontaneous subarachnoid hemorrhage would include things like vascular malformations, such as AVMs, dural AV fistulas, or cavernomas, and those would account for about 10% of spontaneous subarachnoid hemorrhages. We also think about things like intracranial artery dissections, cerebral amyloid angiopathy, reversible cerebral vasoconstriction syndrome, or RCVS, cerebral venous sinus thrombosis, or CVST, infectious meningitis, and very rarely cerebral vasculitis. But here's the challenge. Trauma can cause subarachnoid hemorrhage, but subarachnoid hemorrhage can also cause trauma by causing patients to syncopize or fall at the outset. So two clues that you can use to help you distinguish whether the trauma or the subarachnoid hemorrhage came first are your history and your imaging features. So on history, did the headache precede the patient's fall? Did the patient syncopize or lose consciousness and then fall? Or did they have a mechanical fall that was then followed by headache, altered LOC, and loss of consciousness? You can also look at imaging features, especially subarachnoid hemorrhage location, to point you towards the potential etiology. So in traumatic subarachnoid hemorrhage, where the trauma has caused a shearing force in the small bridging vessels of the subarachnoid space, the subarachnoid hemorrhage bleed usually appears at the periphery of the brain, so in the sulci at the edges of the cerebral hemispheres. Now, trauma can still cause subarachnoid hemorrhage in the deeper structures of the brain, but much less commonly so. Whereas in spontaneous or non-traumatic subarachnoid hemorrhage, where most cases, as we talked about before, are caused by aneurysm rupture, bleeding tends to favor the deeper structures and the CSF cisterns near the brainstem and the circle of Willis, because that's where aneurysms most commonly occur. So given the location of our patient's subarachnoid hemorrhage in the deeper regions of the brain, he needs a CT head angiogram to see if there are any vascular or aneurysmal lesions that could have caused his bleed. If a vascular lesion, like an aneurysm, is discovered on CT angiogram as the cause of a subarachnoid hemorrhage, we need to consult our neurosurgical colleagues early to consider intervention, like endovascular coiling or neurosurgical clipping. If there is no vascular lesion on the CT angiogram, then the bleed is most likely to be traumatic, and neurosurgery is most likely to recommend observation with repeat plain CT head at 24 hours. However, it's still important to involve neurosurgery consultants for subarachnoid hemorrhage in unusual locations, like deeper CSF spaces, since CTA can still miss small bleeding aneurysms, especially if they're less than 3 millimeters in size. And so catheter-directed digital subtraction angiography, or DSA, is actually the gold standard to pick up these smaller aneurysms. So if your location of the subarachnoid hemorrhage looks unusual, neurosurgery or stroke consultants may still recommend further testing to rule out a smaller bleeding aneurysm if the bleed is severe or the story around the trauma history is less clear.
Yeah, I've actually had a couple of patients just like this over the last few years where you can't get a history. They have amnesia for the event. They have amnesia before the event. They don't remember having a headache. And the last one I had, the findings were just like this one. It was deep space blood, nothing on the periphery. The CT angiogram did not show an aneurysm, and so it was presumed to be traumatic. And the neurosurgeon did say it was unusual for that kind of subarachnoid bleed to be traumatic. But in this case, in the end, they presumed that it was all traumatic, and neurosurgery just suggested doing another CAT scan in 24 hours and have them admitted at our local community hospital rather than being transferred. I think that's a good background in terms of just remembering that the most common cause of subarachnoid hemorrhage is actually traumatic. And what we're going to be talking about pretty much for the rest of this podcast is non-traumatic subarachnoid hemorrhage. Now, I did mention at the top of the podcast that we miss as much as 7% of these cases. The obvious question there is, why do we miss spontaneous subarachnoid hemorrhage so much? Dr. Perry?
So we miss the diagnosis of subarachnoid hemorrhage primarily because we often don't think about it in appropriate patients. So once you've identified appropriate patients, you need to then appropriately investigate them. And this is often a step that is missed. You need to obtain a non-contrast CT of the head and follow that with subsequent testing when it is required. So a lot of patients that are at risk aren't sent for CT head. And this can be for a variety of reasons. It may not be that they don't have a CT scanner readily available. They may have to transport the patient. But that is by far and away the number one reason why patients don't get investigated when they ought to. The other reason is that clinicians sometimes underappreciate just how sick the patient is. As you mentioned earlier, Anton, up to about half of patients with subarachnoid hemorrhage look well when they first come in. They just have a headache. They don't have neurological findings, and they actually appear relatively well, and they're only complaining of a headache, or at least that's their main complaint. So clinicians who don't see subarachnoid hemorrhage that often underappreciate that they could actually be harboring a sentinel bleed, and therefore they treat the symptoms rather than investigating for the etiology. So in summary, clinicians miss the diagnosis because they fail to appreciate the clinical spectrum of subarachnoid hemorrhage, and the patients can look well. They fail to investigate at-risk patients, and they fail to obtain the appropriate imaging or testing in at-risk patients. So that would be starting with a non-contrast CT and then proceeding on to other tests when there's a delayed presentation or the patient's at particularly high risk. And that would entail either obtaining a lumbar puncture and or a CTA of the brain.
All right, yeah, we'll get onto that great debate in a little bit, I promise. But I want to talk more specifically about the history. Given that we don't even get a CT in many of these cases, so 3/4 of the cases that are missed are because we just don't get a CT in the first place. So we really need to drill into the history to figure out which of those patients who look well need a CT. So let's say our 55-year-old patient that I presented at the top of the podcast simply had an abrupt onset headache without loss of consciousness, and you're going to ask him in the history a bunch of questions to figure out whether you really need to go to a CT. I want to start with the so-called thunderclap headache onset. How do you actually ask patients when you're practicing in the emergency department? How do you ask them about their headache onset? Because, my experience is that if you ask them if it was sudden or gradual, even if it was gradual, they almost always say sudden because to them, yesterday they didn't have a headache, today they do have a headache, so that's sudden, even if it came on gradually over 12 hours. So how do you actually elicit that thunderclap headache story?
Thunderclap can mean lots of different things to different clinicians. So certainly within the Ottawa subarachnoid hemorrhage rule, which we'll talk about more later, when we talk about thunderclap, we're talking about instantly peaking headache. And it's a severe headache. So when I'm talking with patients, I ask them, when did they first notice the headache? I often even ask them, what were you doing when you first noticed the headache? And then I say, okay, and how severe was the headache when you first noticed it from a scale of 0 to 10? And then I ask, okay, so now did it progress or did it get worse following that time period? Yes. Then when did that headache reach its maximum intensity? And then again, ask them, okay, what was the intensity from 0 to 10? And then that gives me a very good idea. Was it within moments? Was it immediately, instantly worse? Or did it actually take quite some time to reach maximum intensity? If it took longer than an hour, most cases I'm not terribly worried about subarachnoid hemorrhage anymore. But if it took less than an hour, then I'm definitely quite worried about subarachnoid hemorrhage and would then talk a bit more about other risk factors. But to be a true thunderclap, it should have instantly peaked. So basically, it wasn't there one moment and boom, next moment, severe headache, 9, 10 on 10, very, very severe headache. So that's what I would elicit as being a thunderclap headache.
Okay, that nicely explains what a thunderclap headache is. And in order for us to catch all these subarachnoid hemorrhages, it sounds like we should be including patients who have a headache that peaks within 1 hour, even though there's very few patients that have their subarachnoid hemorrhage headache peak at 55 minutes. But just to be all inclusive, it makes sense to use that 1 hour rule. What else are you going to ask on history? I mean, even just based on your fantastic subarachnoid hemorrhage rule, we'll talk about that in a little bit, but what are some of the other things that you look for on history? Let's say the patient does say they have a thunderclap headache based on how you asked it so eloquently. What else are you going to ask them for? What are some of the features on history that have high likelihood ratios for subarachnoid hemorrhage?
I should also mention that for those patients where the headache does take longer, where it's been sort of progressing longer than an hour, the other follow-up question I do kind of inquire is whether the headache came on strong, plateaued, or even lessened somewhat, stayed static for a while, and then suddenly went up really, really quickly again. Because there I do actually worry about rebleeding happening, which is a concern. So that is the other subtlety that's actually quite important not to miss. So I kind of asked them, okay, it started then, it peaked here. What happened in between? Did it just progressively get worse throughout that time period? Or did it come up, stay one level, and then get worse again? And get them to try and describe that ensuing period a little bit more granularly so that I know, did it peak again? Because those ones you would be worried about as well.
Great nuance there, Master Clinician Pearl. Yeah. All right. And in terms of on the history, what are some of the other features that are sort of high likelihood ratio features for subarachnoid hemorrhage?
Yeah, so certainly the symptom of neck pain or stiffness is quite important. That's one that I certainly would want to elicit. I want to know if they had any loss of consciousness, especially if it's true loss of consciousness. We talk about witness loss of consciousness. What we're really trying to nail down is, was it a true loss of consciousness, or were they just kind of feeling weak and lightheaded and unwell, and rather than a true loss of consciousness episode? We want to know, what were they doing during the onset of the headache? Was it during some kind of exertional activity or not? And we also want to know about other risk factors. So do they have any prior history of subarachnoid hemorrhage or known brain aneurysms? Those patients are going to be at high risk for subsequent recurrence of either subarachnoid hemorrhage or rupture or forming new aneurysms. You also want to know about family history. Do they have first-degree relatives that have had subarachnoid hemorrhage? If they have any connective tissue disorders, alcoholism, those would all be sort of important questions to ask. So you want to ask about vomiting. Vomiting happens in probably close to half of cases of subarachnoid hemorrhage. It does occur in patients with migraine or some other headache disorders, but it certainly frequently occurs with subarachnoid hemorrhage.
All right. So those are some of the things you want to ask for in history: neck pain or stiffness, vomiting. There's always comes up the worst headache of my life. And I find that one personally not very helpful. It's something that people talk about all the time, and they ask patients, was that the worst headache of your life? And if they say no, then you're thinking, oh, well, that rules out a subarachnoid hemorrhage, but that would be a very risky thing to do, I would think. What do you make of worst headache of life? Should we just not be using that at all and ignore it? What does the literature say about worst headache of life?
We looked at this in thousands of patients, and we found that it certainly is quite common in patients with subarachnoid hemorrhage. Probably, I think it was 92% of the cases did report that it was the worst headache of life. However, in the other patients in our study, they also frequently reported worst headache of my life. So it was present in the high 70%. So you're not talking about a big difference between those with subarachnoid hemorrhage and those without. So in the end, it doesn't really help you tease out the patient with subarachnoid hemorrhage versus those that don't.
Okay, so suffice to say that worst headache of life has poor discriminatory power for subarachnoid hemorrhage, and it can be misleading if they say it's not the worst headache of their life.
And of course, it depends how you ask it, because we also looked at our inter-observer agreement for that variable, and it was horrible. So the answer that one physician would get and the other physician would get, it often wasn't the same. So the patients would say one thing at one point and then would change with the other physician. And that might be because of the way they were asked, or it might even been asked if they got a little bit of pain medication, they might have realized, oh no, actually, that's not really the worst. I have had worse ones before, but it was just really bad. I wanted something for pain.
Yeah, the one other question I had about headache is that sometimes we erroneously assume that if the patient's had a similar headache in the past, that it's not a subarachnoid hemorrhage. However, a sentinel bleed could certainly give you a headache that's very similar to the subarachnoid hemorrhage headache that the patient is having on their present visit. On the flip side, my understanding is that if someone says that they've had a similar headache 3 or more times in the past, that actually decreases the likelihood that it's a subarachnoid hemorrhage. Could you speak to a little bit on previous headache and how we tease out whether a previous headache increases the risk of subarachnoid hemorrhage or decreases the risk of subarachnoid hemorrhage being the diagnosis?
Essentially, you're absolutely right. Remember, patients can have a rebleed. So a sentinel headache is essentially just a small subarachnoid hemorrhage, right? So they've just had a small leak. They only have a headache or very minimal symptoms. And then they go on and have a rebleed, which then gets diagnosed. Typically it's bigger and they're established to have a subarachnoid hemorrhage. So if a patient has a similar headache in the recent past, especially within a week, 2 weeks, even a month, some studies would even say up to 6 months, that person could be certainly just having a rebleed rather than it being more of an established headache pattern that they have. So that's why if you have 3 or more headaches in a span of greater than 6 months, well, that's now getting highly unlikely to be a subarachnoid hemorrhage. Remember, these are arteries that are bleeding under high pressure. So think about it like strike 3, you're kind of out. Like you're going to be having some significant problems if you've had 3 subarachnoid hemorrhages. And the probability of you having a leaking aneurysm 3 times and not getting some kind of catastrophic bleed is just very, very small, especially when it's in a duration greater than 6 months.
All right, fantastic. I love all these granular details that are so important in just the history taking. Dr. Lin, any other historical features that Dr. Perry didn't mention that you ask about in your history for subarachnoid hemorrhage?
I totally agree with all of the points that Dr. Perry has pointed out already for us. I'll add in a couple of my own. So I think about risk factors for aneurysm formation and rupture. Things like your standard vascular risk factors, still important to ask about. Hypertension, smoking, and older age, especially over the age of 50, are particularly linked with risk for aneurysm. Personal history of cerebral aneurysm, like Dr. Perry was mentioning as well, and especially if there has been documentation of an aneurysm greater than 5 millimeters in size, of any degree of growth on serial imaging in the past, or an aneurysm that's located in the posterior circulation vessels, because all of those have been shown to have a higher risk for rupture. Genetic risk factors, like Dr. Perry mentioned as well. So that family history of cerebral aneurysms or aneurysmal subarachnoid hemorrhage, connective tissue diseases, especially Ehlers-Danlos, a little bit less so Marfan's, and then autosomal dominant polycystic kidney disease are sort of part of that list of risk factors. And then high risk substance use. We talked a little bit about binge or chronic alcohol use, and then also sympathomimetic use. So cocaine, methamphetamines, which we're seeing a lot of these days. And then I also think about some of those presenting features and red flags. Many of them are captured already in the Ottawa subarachnoid hemorrhage rule. So again, that exertional onset of the headache is very worrisome for me. If somebody says it happened while I was doing sports, while I was engaging in sexual activity, those should be concerning. These patients can present with low-grade fever as well from meningeal irritation due to the subarachnoid blood. So not automatically just thinking of meningitis from an infectious source, but also potentially from subarachnoid as a potential here too. And then as we mentioned, that preceding sentinel headache within the last month especially, and especially if there was no kind of preceding chronic headache history like we talked about greater than a month prior. And then I also have this list of what I call headache plus. So headache plus altered level of consciousness. So persistent GCS of less than 15. Headache plus seizure. Headache plus loss of consciousness or syncope. Headache plus unilateral neck pain. And headache plus focal neurodeficits.
There's actually quite a few historical details that are important in suspecting this. And I suspect that if our listeners asked the majority of these questions that we've been talking about, that miss rate of 7% will be more like less than 1%, which will save lots of lives and disability. So hopefully we're getting somewhere already. Do you dread doing your clinical notes every shift? Do you feel like you can never get ahead of charting? If you're shaking your head yes, keep listening. Freed is an AI scribe that listens, transcribes, and writes medical documentation for you. Notes are written in your style and ready the moment the patient encounter is over. Just imagine leaving work at the same time as your last patient. Freed is HIPAA compliant, secure, and takes less than 30 seconds to learn. Artificial intelligence can't replace you, but it can do the administrative work that no human should be subjected to. All the magic happens in just a few clicks so that you can spend less energy on charting and more time on doing what you do best. Freed learns your style over time, just like a human scribe, and it'll never quit on you. More than 6,000 of your clinician colleagues already use Freed AI. Get back to spending your clinical time caring for patients and let Freed AI do the rest. Head over to getfreed.ai and use the code EMC50 to receive $50 off your first month with Freed. That's getfreed.ai with the code EMC50. Getting back to the thunderclap headache, or the truly abrupt onset of headache, we don't want to forget that there's a list out there of life-threatening or disability-causing causes of headache that present just like a subarachnoid hemorrhage does. So before we dive into more details about subarachnoid hemorrhage, Dr. Lin, could you just run through for us the causes of thunderclap headache that are not subarachnoid hemorrhage that we don't want to miss? We want to avoid that premature closure bias where, we say, oh, this is not a subarachnoid hemorrhage after our workup, we're finished.
I think this is a super important point, Anton, that we have to think beyond just subarachnoid hemorrhage when we're thinking about thunderclap headache approach. So I'm going to break it down into more common differential diagnoses and less common differential diagnoses for thunderclap headache. Under the more common differential diagnoses that we might encounter causing a thunderclap headache presentation, I think about RCVS, so reversible cerebral vasoconstriction syndrome. This is probably the most common alternative cause that we would see on a regular clinical basis. Now, it's important to know that RCVS can actually coincide with subarachnoid hemorrhage. Sometimes it can actually cause a small subarachnoid hemorrhage. We can also see associated lobar hemorrhage, vasogenic edema, or infarcts on plain CT head with RCVS as well. And CT angiogram for this condition usually will show multifocal artery narrowing that is dynamic on repeat follow-up CTA. It's actually common to miss this diagnosis on initial imaging. Additionally, common differential diagnoses, intracranial hemorrhage, so a spontaneous hemorrhagic stroke, less so to see a thunderclap headache with an acute ischemic stroke. And then, of course, your carotid, vertebral, and intracranial artery dissections, you can certainly present with a thunderclap headache, and we would often need a CT angiogram to diagnose these. And then, of course, not to forget about that infectious meningitis picture. So viral or bacterial meningitis can certainly present as a thunderclap headache, and we would need an LP to diagnose those.
Yeah, I've actually had a few patients with subarachnoid who have a low-grade fever. And in your initial assessment, you're like, oh, that sounds like they have meningitis. But their story kind of sounds like a subarachnoid hemorrhage, and you get all confused. But I think that's just a good little point to remember, that patients with subarachnoid hemorrhage can have a low-grade fever as well.
And then, of course, there's the less common differential diagnoses for thunderclap headache. So things that I would think about here would include CVST, so cerebral venous sinus thrombosis. You do need a CT venogram to diagnose this. And I think of this sometimes like the PE of the brain. So it's more common in females, pregnant patients, postpartum patients, smokers, and patients on hormone therapies. And then you have your PRES, so your posterior reversible encephalopathy syndrome, which is essentially an acute hypertensive crisis. Usually your tip-off here is the severely elevated blood pressure that's often not subtle. And then you will see reversibility of the headache, the altered level of consciousness as you start to bring down that blood pressure. So that's your major clue. Pituitary apoplexy. So this is a pituitary bleed that you can see on CT alone, but sometimes you do need MRI to confirm it. And risk factors for this would include uncontrolled hypertension, a pituitary adenoma or mass, and pregnancy or peripartum. And then the last thing that I'll throw in here as well is acute angle closure glaucoma of the eye. So although this is a primary ocular problem, it can actually present like a thunderclap headache because it can come on suddenly. It can precipitate a severe headache behind the symptomatic eye. And often patients are in so much pain that they may not be able to distinguish between the head pain versus the eye pain. So just have a quick look at the patient's eyes for asymmetric redness, pain, blurry vision, or a fixed pupil, and consider an IOP check quickly if present at the bedside, because if you have a tonopen, this is a fairly straightforward diagnosis to make, but it can definitely trip you up. And I have actually seen a couple of cases of acute angle closure glaucoma that come in with EMS with concerns for a possible subarachnoid or intracranial hemorrhage.
Absolutely. What a great list. So in terms of what can commonly cause a thunderclap headache, certainly ICH is a huge one. We have to think about dissections in the neck. We have to think about RCVS, although we probably miss a lot of those. And the way we pick those up is if there's a hemorrhage there, we just call it an ICH or an SAH. And then infectious meningitis. I've been surprised how many patients over the years I've worked up for subarachnoid hemorrhage. I'm convinced that they have a subarachnoid hemorrhage. And then it turns out that their white blood cell count is high. And then I end up putting them on antibiotics and their culture comes back positive for bacterial meningitis. So those are the big ones that can commonly present as thunderclap headache. Although the meningitis one, I think I'll never understand why they present with that abrupt onset headache, but I have seen it for sure. Then there's cerebral venous thrombosis. There's PRES, or acute hypertensive crisis, pituitary apoplexy, and then acute angle closure glaucoma, which I've seen present just as vertigo. I've seen present just with headache. I've seen acute angle closure glaucoma present in a myriad of strange ways just to mess with us and make our lives even that much more difficult. All right. I will refer our listeners to our pair of main episode podcasts on red flag headaches for more on cervical artery dissection and cerebral venous thrombosis and some of the other ones we mentioned. That's episodes 161 and episode 181. Okay, so that's a lot about the history. I want to talk now about physical exam. Dr. Lin, anything in particular you're looking for in physical exam which will increase your likelihood that it's a subarachnoid? I mean, obviously, if they have obvious focal neurologic deficits, you're going to be scanning them anyways. But what are some of the more subtle things that you're looking for on physical exam? You know, let's say you have a patient who has headache alone and you're like, oh, okay, it was sort of an abrupt onset, but not really. The patient can't really remember. They're not sure. They're vague historians. What are you going to look for on physical exam?
I think it's important for all headache patients, but especially thunderclap headache patients, to have a screening neuroexam to pick up on those potential focal deficits, because I think it's our ability to detect it that is really, really key here. And I'm not referring to that detailed reflex hammer style neuroexam that you were taught in med school, but rather a basic ED screening neuroexam that has looked at basic kind of level of consciousness, cranial nerves, especially the eyes, speech, motor, sensation, and coordination and gait in broad strokes. So things that I pay particular close attention to in thunderclap headache patients are that objective neck stiffness meningismus that Dr. Perry had mentioned earlier because of its high likelihood ratio association with subarachnoid hemorrhage. And then I think about the eyes, really. So looking especially at the pupils and the gaze alignment. So uneven pupils or diplopia or disconjugate gaze can come from cranial nerve 3, 4, or 6 palsies that are caused by aneurysm mass effect. So I actually think it's not that important to distinguish which specific cranial nerve palsy you're dealing with, 3, 4, or 6, but rather to screen for the pupils and to screen for the extraocular movements to recognize that there is a new unevenness or that there is a new diplopia. And then, of course, those stroke-like focal neurodeficits that we talk about, but especially motor and speech.
Fantastic. Neck stiffness is a big one. Very high likelihood ratio for neck stiffness. And then just doing your good, solid screening neurologic exam, especially the eyes are the gateway to the soul and the brain. So make sure you do a good eye exam as well. And talking about an eye exam, one thing that I've only seen once before, only because the neurologist was in the department at the time that I had this patient, he showed me a subhyaloid hemorrhage, which apparently is diagnostic for subarachnoid hemorrhage, but it's basically this red splotch that you see on fundoscopic exam. And even I, who do not have good skills in fundoscopy, even I could see it after the neurologist showed me. But I think it is worth looking at the fundi. You want to look at the fundi to look at optic disc margins and signs of raised intracranial pressure anyhow for your headache patients. But if you do see the subhyaloid hemorrhage, it's kind of cool because you can pretty much make the diagnosis right at the bedside. I want to move on now to the workup of subarachnoid hemorrhage. And the first decision point is whether or not to work the patient up in the first place. And the Ottawa Subarachnoid Hemorrhage Clinical Decision Tool, to help decide whether or not to work up the patient, has a sensitivity of 100% and a specificity of 15%. We'll have the Ottawa Subarachnoid Hemorrhage rule in the show notes, but here it is briefly. For alert adults with new severe non-traumatic headache reaching maximum intensity within 1 hour, there's that 1 hour we were talking about, excluding patients with new neurologic deficit, so these are patients with headache alone, excluding patients with previous aneurysms, previous subarachnoid hemorrhage, previous brain tumor, or a history of 3 or more recurrent headaches over the last 6 months. We were talking about previous headaches, and 1 previous headache within the last month actually increases your risk, but 3 or more recurrent headaches over the last 6 months decreases your risk. So excluding those patients, you should investigate if you have 1 or more of the following. Number 1, age of 40 or older. So Dr. Perry and I are at risk right there. Instantly peaking pain or limited neck flexion on exam, neck pain or stiffness on history, and witness loss of consciousness. So again, the items, you just need 1 of these after you've had your exclusions: age over 40, neck pain or stiffness on history, witness loss of consciousness, onset during exertion, instantly peaking pain, or limited neck flexion on exam. Now, there have been some criticisms of the rule. One, that there's poor inter-observer reliability, and that a subsequent study suggested that the rule would actually increase CT and LP use with its specificity of only 15%. So, Dr. Perry, here's your chance to answer all those criticisms. Given these criticisms of poor inter-observer reliability and some of the subsequent studies done on the wonderful rule, what do you suggest should be the practical application of the Ottawa Subarachnoid Hemorrhage rule in everyday practice? And what do you think of these criticisms?
Yeah, sure, Anton. So we've studied subarachnoid hemorrhage and acute headache extensively. We've enrolled in total getting close to about 8,000 acute headache patients that are potentially at risk for subarachnoid hemorrhage. And of those, over 400 of those patients have actually had a subarachnoid hemorrhage. So this is probably the largest group of studies done prospectively in the world. So it really does give us a wealth of new knowledge that we didn't previously have. So when you do these studies, it is very difficult to measure inter-observer reliability. So when we embarked on this series of studies, we did actually put a lot of effort, especially early on, in assessing each of the variables to determine if they had moderate to high inter-observer reliability. So what that means is you get 2 doctors to basically independently assess the patient for the list of variables that we're collecting, and then we can compare the results. And we use something called kappa statistics most of the time to assess this. And anything over a kappa value of 0.6 is generally moderate degree of inter-observer reliability, which is what you want to see. You want to see that or higher when you're developing these rules. So that was actually one of our criteria for selecting the variables that went into the Ottawa Subarachnoid Hemorrhage rule. So I do feel quite comfortable that our variables all actually have quite good inter-observer reliability. But the problem is getting that second doctor to do it. So in our first study, we really put a lot of effort into this. We had over 100 doctors doing this with patients. And so we actually had some fairly good measurements of inter-observer reliability. Most studies, even our own study in our subsequent JAMA paper, we didn't have good numbers of inter-observer reliability. It's just really, really difficult to stop a practicing physician when they're really, really busy to stop what they're doing and go ask the patients the same sort of questions again shortly after the first doctor did. So it often isn't done in most studies. and not done well when it is. So I feel quite comfortable with our inter-observer reliability of these variables. Regarding the low specificity, well, that's true. It is much lower than we had hoped. Specificity of 15% isn't as high as we would like it to be. So that's just because of the nature of trying to develop a rule with 100% sensitivity. So when you do that, you basically will lower your specificity. And so therefore you are going to end up over-investigating as default. But when we, again, went into this, we knew we'd surveyed emergency doctors. We knew they wanted something 99% sensitive or better. That's extremely difficult to achieve. Therefore, you're going to lose some of that specificity and over-investigate patients to a certain extent, but that's by intention. We really wanted something that we knew that the doctors can rely on and use to identify virtually every patient with subarachnoid hemorrhage. Now, is it going to lead to over-investigation? I can clearly say no. We actually know this because we actually did a study looking at the implementation of the Ottawa subarachnoid hemorrhage rule, and it did not increase imaging. In fact, it basically stabilized the investigation rates before and after in terms of your plain CT, and it decreased your use of lumbar puncture and CTA in those patients who didn't necessarily need it because they had early imaging with CT, which we'll talk a bit more about later. So we had actually significantly dropped the rate of CTA or lumbar puncture. And we put those two together because physicians may opt for one route or the other. So we kind of consider those two tests as being two different options that clinicians could use. And it significantly dropped, both statistically and clinically significant, with an absolute drop investigation rate of almost 10%. I can clearly say that it will not lead to increased imaging. It's just going to result in imaging the correct patients so that we're not missing patients that have subarachnoid hemorrhage.
Wow, what a great decision tool. I guess the bottom line there is that, if you use the Ottawa subarachnoid hemorrhage decision tool properly, you really should decrease CT utilization rate and increase your subarachnoid hemorrhage pickup rate. So thank you for going into all those details, Dr. Perry. A word from our sponsor, Metricade, the experts on scheduling systems. Since 2015, I've been using Metricade, the incredible self-scheduling system that has made my life and the lives of my colleagues so much easier. Metricade can really help minimize the drawbacks of shift work we all know so well by not only ensuring equitable distribution of shifts, but also integrating circadian rhythm-friendly recovery time into their algorithms. They minimize my sleep deprivation, which allows me to be a better EM doc on shift. I can take better care of my patients and still have energy left after my shifts to enjoy other aspects of my life. Check out metricade.com/EM cases for more details on how this awesome scheduling system works. We know that the accuracy of CT for subarachnoid hemorrhage over time decreases, and that your 6-hour CT head rule, which we haven't talked about yet, which I'd like to talk about now, that rule says that if the CT is done within 6 hours, that the negative predictive value is good enough to stop there and rule out subarachnoid hemorrhage. But before we get into the details of the rule, can you give us a sense of how accurate exactly a non-contrast CT is for the diagnosis of subarachnoid hemorrhage over time? I mean, my understanding is that as CTs have become better and better over the last couple of decades, that the accuracy, at least in retrospective observational studies, is really good up to as much as 24 hours. We'll talk about the 6-hour rule in a second, but I think most of us know about it already and are pretty comfortable ruling out subarachnoid hemorrhage within 6 hours of onset. Could we stretch it out to 24 hours? Could you just sort of dig into the literature for us about the accuracy of CT over time and the most modern literature? Because it does seem to be changing every decade.
So certainly the literature has evolved over time. Back in 2011, in our initial BMJ publication on this topic, we were using third generation thin sliced CT scanners. So the technology has advanced somewhat since that time. Mainly the feature that keeps happening is that we get thinner and thinner brain slices, which does allow us to identify very small quantities of blood more easily. So that's the main difference in terms of the technology that we use today versus back when we did the original study. Many of the studies now do suggest that it may be 95, maybe 93%. There's been certainly several studies that have looked at this. These studies have tended to be primarily retrospective studies, which can have some limitations to this. So I suspect it certainly is into the 90% sensitive. An exact number's difficult to say without getting a new large prospective study. But I would say it certainly is likely over 90% up until that 12-hour mark and probably even up to that 24-hour mark. But where you draw the line is difficult. We incidentally picked 6 hours because there was a study prior to ours that showed a 98% sensitivity at 12 hours. It was a retrospective study, and we were planning this big prospective study, so we very scientifically chopped that time in half and came up with 6 hours. Now we probably wish we would have picked 12 or something like that, which might have helped people a bit more, especially with our current ED wait times.
Suffice to say that after 24 hours, we're getting probably below 90%, even with the modern scanners. There have been some retrospective studies to suggest that up to 24 hours, that the sensitivity is in the 90s. One study from 2022 found a sensitivity of 99.3% up to 24 hours. But again, that's a retrospective single center study. So we can't really hang our hat on that. This is important because that patient who presents at 12 hours or 16 hours or 22 hours, and you have a low pretest probability to start with, whether you need to go beyond that CT becomes a very tough decision. We certainly know that under 6 hours that we can feel pretty comfortable. And I want to talk a little bit more about the 6-hour rule. So this was your landmark study a few years back entitled Sensitivity of CT Performed Within 6 Hours of Onset of Headache for Diagnosis of Subarachnoid Hemorrhage, a large prospective multi-center study. And it showed 100% sensitivity for non-contrast CT at identifying subarachnoid blood when done within 6 hours of headache onset. And it was interpreted by an experienced radiologist. I wanted to talk a little bit about validation of that study as well. There was a validation study, I understand, in 2020 that found only a 95.5% sensitivity with 5 subarachnoid hemorrhages missed. And it's kind of important to get into the details of this. So 2 of them were false positives. 1 was missed by the radiologist, and 2 of them were true misses. So for the true misses, you could say it's more like a 97% sensitivity on this 2020 study, or a 98% sensitivity when you combine the 2 studies. So considering that a subarachnoid bleed is likely to be present in only 1 out of 100 patients who present to the ED with an acute headache, then with a 98% sensitivity, we're talking 1 miss every 40 years of practice by non-contrast CT within 6 hours, which, depending on your risk tolerance, may be acceptable or maybe not. So, Dr. Perry, what's your take on the accuracy and the practical application of the 6-hour rule? I mean, I think most people out there are totally sold on the 6-hour rule, but there is this validation study which kind of put it into question. So I just want to give you a chance to sort of address that validation study and suggested that maybe it's not perfect.
Yeah, so this was our own validation study. So I do know quite a lot of the details of this study. And essentially, we want to report the worst case scenario that's out there. So there were 5 patients that were not identified with the 6-hour rule. 2 of those were felt to be a misdiagnosis. So how do we determine that? Well, that meant that they had some blood in the lumbar puncture, small numbers of red blood cells, and positive angiogram. And essentially, those patients were deemed to be basically a false positive by the treating neurosurgeon. So it wasn't that we kind of determined that they were false negative on our own. We actually went to the records and the treating neurosurgeons to determine whether they thought that this aneurysm was actually responsible for the headache or not. And those ones, they were not. But that being said, some say, well, that could have been. So that's why they were included as missed. One of them, there was a radiologist who missed a small amount of blood. It was a very small subarachnoid hemorrhage, but it was visible there when we showed several scans to other radiologists who readily did identify the blood. So that one was more of a radiologist miss. But that's an important thing to consider, is that your radiologists are people. And depending what time of day they're looking at this, whether or not they've had their coffee, they still can miss. Even very experienced radiologists can occasionally miss a subarachnoid hemorrhage on a scan. So that's important to keep in mind. The fourth case was a non-aneurysmal subarachnoid hemorrhage. So it was a dural fistula. And so this is essentially a miss of a subarachnoid hemorrhage, but it wasn't a missed aneurysm. It was a missed dural fistula, some of which you don't even see on a CTA, and many of which are treated conservatively. So, but that's still, again, a worst case scenario, putting that in as a miss. And finally, the last one, which I would say is definitely a true miss, was somebody who was profoundly anemic. And they did have a very small aneurysm that was picked up and managed. It was smaller than we typically think about, because usually we think about 5 millimeters or more. This one was only 3 millimeters, but the treating physicians did believe that that was the cause of the headache. So obviously that would count as a misbleed. So in summary, if you're not anemic and you get an early CT scan, the probability of you missing it is likely much less than even 1%. But that's sort of a worst case scenario. So how do I interpret this? Well, I would say that I certainly feel very comfortable using it. And I basically have a chat with the patient. I let them know, okay, your scan's negative. It was done early. So we now know that your probability of having a bleeding brain aneurysm, which can be disabling or even life-threatening, is now less than 1%. It's significantly less than that, but we can continue on and try and reduce that risk even further by doing a lumbar puncture. Talk a bit about what that is, assuming that the lumbar puncture is appropriate for the patient, or CTA if it's not. We talk about those tests, and then sort of have a shared decision-making with the patient to determine whether or not they want to proceed on to get further testing. In my experience, I've only ever had one patient who's opted to proceed on and get the lumbar puncture. They're quite worried about it, and the lumbar puncture was negative, but the patient was more reassured, so that was okay in my opinion. The one exception I would say to that is patients that are really ultra high risk. Again, so people that they've had a previous subarachnoid hemorrhage, they're known to have aneurysms. Those patients I still worry about. Patients that come in with the perfect story. So they're 50 years old. Their headache came on 10, instantly peaking, getting hit behind the head with a baseball bat. They've been vomiting. They're hypertensive, and they just don't look well. And they've got neck stiffness. Well, that patient, I'm probably still going to feel somewhat uncomfortable and actually suggest to them, even though their risk is probably still only worst case scenario in the 1% range, I probably would still suggest that we proceed on and get some further testing in that patient. But again, would have that shared decision making. And sometimes patients have turned me down when I've had that shared decision making in that case. But that's my approach.
It's incredibly reasonable. Very Canadian of you, Dr. Perry. Incredibly reasonable. I just want to highlight one clinical pitfall there, is that patients with severe anemia, you need to interpret the plain CT head in a totally different light, because those patients can hide their bleeds, no matter what kind of bleed it is, actually. So if someone's got a hemoglobin of 60, or in US, that would be a hemoglobin of 6, you really should not rely on a negative CT to be sure that there's no bleed there. So that's a really great clinical pearl there. Dr. Lin, are you sold on the 6-hour rule? So we're still talking under 6 hours that they present. If you get a negative plain CT read by an experienced radiologist, if it is negative, you are done working up subarachnoid hemorrhage.
Anton, I am sold on the 6-hour CT head rule. I think it makes a lot of sense from a risk stratification standpoint, which is really what our job is. And often, as Dr. Perry mentioned, when I share the post-test risk with patients and say this is far less than 1% chance that we're missing this other thing, I find that patients are very reassured. And unless I'm looking for something else, like a meningitis, for example, I feel quite comfortable stopping there.
Okay, yeah, it brings up the point again that don't forget your differential diagnosis of thunderclap headache, because you might stop there if subarachnoid hemorrhage is really your only concern. But if you're concerned for a dissection or something else, you might need to go on to a CTA, or if you're concerned for meningitis, you might need to go on to an LP. That's all we'll say about the 6-hour rule for now. Let's move on to what to do after 6 hours of symptom onset. Of course, if someone presents after 6 hours, the prevalence of subarachnoid hemorrhage is going to be much lower than the patient who presents within 6 hours, because their headache probably wasn't that bad if they took their time coming to the emergency department. So keeping that in mind, we've talked about the test characteristics of non-contrast CT after 6 hours, that even within 24 hours with a modern scanner, you're looking at 90 plus sensitivity. But the question and the big debate really comes down to what to do next after 6 hours. And there's really three choices here. After 6 hours, we can say, well, up to 24 hours, the plain CT is 90 plus sensitive, and that might be good enough for some clinicians. The second option would be to do a CT angiogram looking for an aneurysm that could be clipped. And the third option is doing an LP. And this is one of the sort of great debates out there of what to do after a negative plain CT after 6 hours, an LP or a CT angiogram or nothing. I'm going to list about a dozen considerations to think about when you're making this decision, because there's a lot of factors coming into play, and then we'll hear from Dr. Lin and Dr. Perry what their sort of algorithm is. So number one, it's important to know that CTA rules out clinically important subarachnoid hemorrhage with a very similar efficacy compared to LP. Number two, that a negative CTA in the setting of a negative non-contrast head CT has a post-test probability of subarachnoid hemorrhage of less than 1%. However, there are no large prospective studies looking at the use of CTA for the diagnosis of subarachnoid hemorrhage to date, and this CTA sensitivity only applies to imaging that's read by a qualified neuroradiologist. Number three, there's up to a 25% risk of a post-LP headache, which is relatively easy to treat with caffeine plus minus a spinal patch. Number four, traumatic taps occur in about 10 to 30% of patients, depending on the CSF red cell cutoff you use. And number five, LP adds about 2 to 4 hours to a patient's overall ED length of stay. Number six, CTA increases the total radiation exposure the patient receives. Number seven, there's a chance of anaphylaxis with CT contrast, although very tiny. Number eight, CTA picks up incidental aneurysms that are present in about 2.5% of the population. Unless they're big, like as we were saying before, 5 millimeters in diameter or more, we're actually not sure what to do with those little aneurysms, because 2.5% of the population is walking around with tiny aneurysms that are mostly inconsequential. So the question is, when we get the surgeon involved and we find these incidental aneurysms, they may have to undergo surgical clipping for the aneurysm, which may carry with it some morbidity as well. Number nine, CTA can pick up some alternative diagnoses that may present with thunderclap headache and may not be obvious on plain CT, like cervical artery dissection or RCVS that we discussed a bit earlier. Number 10, not all traumatic subarachnoid hemorrhages are due to aneurysm. As we said near the top, it's about 80-85% that are due to aneurysm, and CTA may not pick up a bleed that is non-aneurysmal. CTA also misses some small aneurysms that are less than 4 millimeters. And then number 11, there are contraindications to LP like coagulopathy, and there are relative contraindications to CTA like anaphylaxis to contrast dye. And then finally, if a test threshold is below 1%, then doing the test will likely cause more harm than good, and then shared decision-making should come into play there. This is a whole long list of factors that make it very complicated. What I'm hoping, Dr. Perry and Dr. Lin, is that you can simplify it for us a bit and tell us what is your approach to the patient who presents with a headache that you have some concern for subarachnoid hemorrhage and the non-contrast CT head after 6 hours of symptom onset is negative? What's your next move? CTA, LP, or nothing? Or, as my guess is, you might say, it depends. Dr. Perry, let's start with you.
Yeah, as you've mentioned, Anton, the list of considerations is long and distinguished. My usual practice would be to perform a lumbar puncture following a non-contrast CT if the patient's presented greater than 6 hours, and I would say within 1 week of their headache onset. So that would be my usual approach. Obviously, if they have contraindications to doing a lumbar puncture, you technically can't do the lumbar puncture, or I'm worried about other disorders that would necessitate getting a CTA, then that would be my next approach. And I'd feel very comfortable with a negative CTA ruling out an aneurysmal subarachnoid hemorrhage. It can miss some types of subarachnoid hemorrhage, but those ones tend to be generally less severe. So I would still be okay with that approach. But because of the incidental aneurysm rate in particular, my approach is to go for a lumbar puncture.
That brings up actually one question I had for you when it comes to LP timing. You said up to 1 week you're comfortable doing an LP. When is it that an LP will no longer pick up subarachnoid blood? I've heard 1 week, I've heard 2 weeks, I've heard a month. At which point would you say, there's no role for LP anymore, I would do a CTA?
I just kind of draw the line at 1 week. And again, we probably did one of the biggest studies prospectively on looking at the utility of CT and LP, the combination sort of approach, and looking to see how sensitive it is for picking up the diagnosis of subarachnoid hemorrhage within 2 weeks. And we did find within 2 weeks, it picked up all the cases. So it was 100% sensitive in our cohort. However, being the lead author on that paper, I also know that there were very few cases between 1 week and 2 weeks. So I don't feel that there's enough evidence in that 1 to 2 week range to sort of hang my hat on it. So because of that, I kind of draw the line at 1 week, because there are certainly a lot of patients within that study that presented up to a week out. So the numbers are reasonably solid to rely on that approach. Beyond a week, I worry that we might not have enough evidence to really be confident in that approach. Therefore, I would go with my surrogate, which would be get the CTA.
Okay, interesting. So if their headache was more than a week ago, then you'd probably go for CTA. I have had cases in the past where the headache was 2 weeks ago. I do a CTA, there's a 3 millimeter aneurysm, and then neurosurgery wants an LP. And then I wonder, what would be the role of the LP in that case?
I would say that's not necessarily completely unreasonable from what the neurosurgeon wants. It probably will still be positive at 2 weeks, but it might not be. So if they can see that it is positive and there's some xanthochromia there, well, then they know that they need to go to the operating room for sure. If it's 3 millimeters, so it's a tiny aneurysm, and there's no xanthochromia, no blood, then they have to make a very hard decision, which is the same hard decision that they face if you get the CTA. Is that aneurysm actually causing this headache? And that's my biggest concern with these incidental aneurysms is, by definition, a symptomatic aneurysm needs surgery. It needs a procedure done to stop it. And all our patients have headaches. So it really puts the neurosurgeon into a corner where the safest thing for them to do medically, legally, is to intervene. But that may not be the best thing for our patient, because these interventions can have real harms. And I've seen patients that have had ischemic strokes, they've had their artery rupture, and they've had devastating outcomes from intervening on what almost certainly was not truly a symptomatic aneurysm. But the neurosurgeon was basically trying to play it safe and intervening in a situation where it takes a lot of courage to look at that aneurysm, even if it's small, and say, no, I don't think it's causing your headache, and to just watch it. Because even if it wasn't responsible for that bleed, if it does bleed anytime in the next several years, well, that family is probably going to come asking for answers. Why didn't you intervene? So it's very, very difficult for the neurosurgeons not to intervene. And let's face it, they're surgeons. Surgeons like to intervene. That's what they're trained to do. And so it takes a very gutsy neurosurgeon to just say, no, that's not the cause, and to watch it. So that's why I tend to lean towards the LP first approach.
All right. Yeah. It sounds like all our patients have headaches, and then we end up getting headaches, and the neurosurgeons get headaches. There's a lot of headaches going around here. So it sounds to me, Dr. Perry, like you lean more towards the side of LP after negative plain CT after 6 hours of symptom onset, unless there's an obvious contraindication to LP, and then you'll go with CTA, or unless that it's more than a week since the onset of headache, then you might do a CTA first. Dr. Lin, what's your approach to CTA versus LP after a negative plain CT after 6 hours of symptom onset?
All right, I'm going to wade into the murky waters of this particular debate, but I'll start by acknowledging that this is the art of medicine, and this is what makes our work very challenging. So I personally agree with all the points that have been raised so far. I use a 3-step approach at the bedside to simplify things for myself as far as decision making. So first, is there a clear indication for CTA? So that would be for patients with pre-existing known cerebral aneurysms. If there's a focal neurologic deficit present, especially if there's that new uneven pupil, diplopia, or motor speech deficits we talked about. If there's associated new unilateral neck pain or trauma that's concerning for me for possible arterial dissection. If there is a clear LP contraindication, so anticoagulation or potentially hardware in situ at the spinal level where I would need to access. If the dry CT is positive for subarachnoid hemorrhage, especially in an unusual location like we talked about before. And again, if it's a delayed presentation like we mentioned, so greater than 1 week out with a highly concerning story. Second, is there a clear indication for LP, especially if I'm concerned about a possible infectious meningitis on the differential? So for me, that's patients who have headache or meningismus plus either low-grade fever or confusion. These are the patients that I'm going to be LPing for sure. And other patients who maybe have an early infectious meningitis but haven't mounted a fever response yet, if they're reliable, I'll often do shared decision making and say, if things get worse or if you spike a fever, please do come back. And I feel comfortable with that approach. Third, for those who fall in the gray zone, where neither CTA nor LP is clearly the path of choice for me, that's where I really lean heavily on that shared decision making with patients. So I really do share with them. For the LP, for example, I'll describe what the procedure is along with the procedural risks. I will let them know that it's more invasive and it risks missing some vascular causes of their headache, but it can also help to rule out, for example, that early meningitis that is not picked up on CTA alone, and it's not going to put them at risk of incidental aneurysm diagnoses. For CTA, I tell patients this is a less invasive approach, but it may miss those early infectious meningitis causes. And there is that 2.5% risk of picking up an incidental aneurysm, which is not a benign finding for patients. It can result in those unnecessary procedures we talked about. It can affect their ability to qualify for disability and life insurance going forward, which can be significant for patients. And it's going to need potentially a follow-up LP anyway if we do find that small aneurysm on CTA that we talked about to see if that aneurysm is symptomatic. So I share all of those things with patients at the bedside. And so just to kind of recap, step 1, is there a clear indication for CTA? Step 2, is there a clear indication for LP? Step 3, if there isn't a clear indication for either, let's do some shared decision-making and move forward.
Brilliantly organized. I love the 3 steps. That was excellent. So we have an incredibly reasonable researcher and an incredibly organized clinician. I love it. I want to move on now to CSF interpretation. But before we do, we need to make it clear that there really is no good evidence to support the practice of waiting 12 hours before performing a lumbar puncture. That seemed to be a common myth from 20 years ago. That'll be enough said on that myth. So let's move on then to CSF interpretation. I first want to get xanthochromia out of the way. Now, in more than 2 decades of practice, I don't think I've ever found xanthochromia to be game-changing, even though I was taught way back in residency that it's pathognomonic for subarachnoid hemorrhage. But that's probably because, as I said earlier, after a negative CT, it may take decades of doing LPs after CT for thunderclap headache to pick up one subarachnoid hemorrhage with LP. My understanding is that close to 0 EDs have access to spectrometry to identify xanthochromia accurately. So, Dr. Perry, first of all, what is xanthochromia? How do we identify it reliably? And is it useful? Like, what role does the identification of xanthochromia play in working up suspected subarachnoid hemorrhage?
Xanthochromia certainly, I would say, is useful when it's there. The issue for us is that it's rarely the measure that really makes us diagnose subarachnoid hemorrhage. So xanthochromia is simply the breakdown products of red blood cells, predominantly bilirubin, oxyhemoglobin. These breakdown products basically cause your normally clear cerebrospinal fluid to become yellow tinted. And essentially what we do is we centrifuge the sample of cerebrospinal fluid and get all the cells to drop at the bottom. You look at the supernant or the top part, and it should be clear. And what they do in the lab is they literally stick a sheet of white paper behind the fluid and say, does it look yellow? And that's visual xanthochromia. When they use spectrophotometry, that they actually look for the bandwidths. If they shine a ray of light through that, and they look for the bandwidths that actually correlate with bilirubin or oxyhemoglobin. And there's several different spectrophotometry definitions of xanthochromia that are out there, some which are better than others. But at the end of the day, in North America, the last time I checked, 97% of emergency departments in North America do not use spectrophotometry. They use the visual method to identify xanthochromia. And it's actually quite reasonable to do so. We did a previous study where we looked at using spectrophotometry versus the method that we use in our center, which is the visual with red blood cells. And we found that that combination was 100% sensitive for identifying cases with subarachnoid hemorrhage. The cases where we use spectrophotometry, it depended which definition we used. Some of them were 100% sensitive, many of them were not. And the false positive rate or the specificity was horrible compared to what we're doing now. And that's even considering the traumatic taps. So it essentially validated what we do in most places in North America, which is use the visual xanthochromia and also assessing for the presence of red blood cells. And no, you do not need to wait to do this because we're using the 2 measures. Red blood cells are there almost immediately after the onset of headache. So you can go right ahead and do your lumbar puncture by the time your CT scan's done, and it will be helpful to interpret for subarachnoid hemorrhage pretty much right away. And the xanthochromia can be present in as short as a couple of hours. It can take up to maybe 12 hours to appear. But again, because we're looking at both red blood cells and xanthochromia, you don't need to wait.
And practically speaking, we're going to be doing an LP generally about 12 hours at least after the onset of headache because we've already done a CT and then waited for the report from the radiologist because we don't want to depend on our own looking at the CT. We want to move on to LP after the radiologist has reported it. So that's going to be probably after 12 hours anyhow. All right. So
one of the rare instances where ED overcrowding has been helpful for us.
Yeah, exactly. All right. I think that's about everything we'd ever want to know about xanthochromia. The next question that always comes up is how few red blood cells do you need to call it negative for subarachnoid hemorrhage on the LP? And the other question is, can you tell from the red blood cell number and the decrease across the 4 tubes if the tap was a traumatic tap or not? So maybe just give us the bottom line here, Dr. Perry. I've heard so many different things about RBCs decreasing by 25% or more from tubes 1 to 4, cutoffs for the 4th tube, when to assume that it's a traumatic tap, when to assume it's not. What's the bottom line for RBCs on your CSF for rule out subarachnoid hemorrhage?
The first thing to consider is that at least 2/3 of your lumbar punctures won't have any bleeding whatsoever. So you don't need to worry about traumatic tap in 2/3 of the time. It's that 1/3 of the time where they're not quite normal. And so in those cases, the looking for a drop is not super helpful because you can get both a traumatic tap and a true subarachnoid hemorrhage. So it's not super helpful. The bottom line is, in my opinion, is the best evidence is probably still from one of our own studies, again, where we took all the patients from all of our original studies and we published in BMJ in 2015, where this study involved lumbar punctures of 1,740 patients, essentially, where we did a lumbar puncture and then we found that using a cutoff of 2,000 times 10 to the power 6 per liter cells, that was our cut point. So if you had less than that, that was a low risk tap. If you had greater than that, that is a high risk tap. So how we interpreted this is basically if you had a low risk number of red blood cells, so less than 2,000, that's typically what your lab, most labs will report it as, and there's no xanthochromia, that patient's a low risk patient. So unless the patient, again, you come back to that clinically high risk patient, unless they fit that bill, you can stop. If your patient is considered still very high risk and that tap was not completely negative, then you need to proceed on and get your CTA. If you get a high risk tap, so greater than 2,000, or you have xanthochromia, then that patient, again, you do need to go on to get a CTA. And if you have xanthochromia there, well, that is a subarachnoid hemorrhage. You're going to go on and get a CTA to determine now is it an aneurysmal subarachnoid hemorrhage and trying to get a bit more of an idea of what the etiology of that subarachnoid hemorrhage is.
Fantastic. So if there's anything to remember, it's that number 2,000 times 10 to the 6 per liter red cells on the fourth tube, because if it's lower than that, then that puts the patient into a low-risk category. We probably don't need to do anything further to rule out subarachnoid hemorrhage. Then the other point is that this idea of the number of RBCs decreasing by more than 25% between tubes 1 and 4, that is not something to hang your hat on. We should sort of ignore that. And then just a plug that I just want to put in there is when you're doing your LP, there are various things, which we've talked about before on EM cases, to do an LP in such a way that it's less likely to be traumatic. So using a smaller needle, using an atraumatic needle, getting your patient comfortable, if you need to, giving them analgesics and or sedation, whatever it takes, taking your time with advancing the needle. There are definitely ways to decrease your traumatic LP rate. And so if you improve your LP skills, then you're less likely to run into a mess of trouble when you have a bunch of RBCs that you're not sure whether it's a traumatic tap or not.
And just to add, Anton, in addition to not only getting fewer red blood cells, if you do the lumbar puncture as you described, you also encounter a much lower rate of post-lumbar puncture headache, which is one of the main complications of doing the lumbar puncture.
Absolutely. All right, we're nearing the end of part 1 of this 2-part series on subarachnoid hemorrhage. Let's just summarize our approach to the workup of subarachnoid hemorrhage in the emergency department. And we'll divide it into under 6 hours and beyond 6 hours. So for under 6 hours, we do a non-contrast CT, and that will be sufficient to rule out a subarachnoid hemorrhage in the majority of patients. If the subarachnoid hemorrhage is your only concern, you can stop there if your CT is done within 6 hours and read by an experienced radiologist. In select high-risk patients for subarachnoid hemorrhage or patients with severe anemia, then you do not want to rely on that plain CT even under 6 hours, and you might want to go on to further testing after that. Between 6 hours and 24 hours, you have the choice of a CT angiogram or an LP, and there's a number of factors to consider for which one you're going to do. You can take Dr. Perry's approach, which is you'll do an LP between 6 hours and 1 week for most of your patients, except for those who have an obvious contraindication to LP, or for those that you are concerned about an alternate diagnosis. Or you can take Dr. Lin's approach, which is the 3-step approach, which goes through First, is there a clear indication for a CTA if you're worried about other vascular lesions besides an aneurysmal subarachnoid hemorrhage? Second, is there a clear indication for LP? And so if you're worried about meningitis, then you'd go with LP. And then for the patients that are in the gray zone, employ shared decision-making to decide whether to do an LP or a CTA. And then if you're going to remember one number when it comes to CSF interpretation, it's 2,000 for the number of RBCs, which would put the patient into a low-risk category if it's less than 2,000, and where you'll need to go on to a CTA if it's more than 2,000. All right, any last clinical pearls or pitfalls to wrap up this part one of our two-part series on subarachnoid hemorrhage?
Yeah, Anton, if I could just add one pearl, which is adding on what Katie said. So if you have somebody with either a complete or a partial third nerve palsy, and you can throw in the fourth or the sixth nerve palsies, those patients actually need a CTA, not a lumbar puncture, because those patients haven't actually had a subarachnoid hemorrhage. They're actually getting their headache from the enlargement of the aneurysm directly. So those patients are actually at high risk of rupture because this aneurysm is growing. So those patients, you actually want to do a CTA to rule out, in particular, PCOM aneurysm, but it could be also other places that is imminently at risk of rupture. And if you do the lumbar puncture, you'll get a negative LP because it hasn't bled yet, but there's a high probability that it may in the very near future.
Excellent, Pearl. And Dr. Lin, any last pearls of wisdom before we wrap up this podcast?
Just remember to think beyond your differential diagnosis of just subarachnoid hemorrhage when you're dealing with thunderclap headaches.
Wonderful. Well, thanks to the two of you for all those amazing, again, the very reasonable approaches and all the nuances and the history and physical and LP interpretation and when to image which patients. Thanks so much for all your insights.
Our pleasure. Thanks for having us.
Great. Thank you for having us.
Can't wait for part 2 where we talk about the sick subarachnoid hemorrhage patient, which is a whole other kettle of fish compared to these patients who present just with a headache alone.